Ladies and gentlemen, welcome to Triple N Media. I am Dr. Nik Nikam. This cardiology seminars is brought to you by Triple N Media. On our YouTube channel, we have more than 200 cardiology lectures. We welcome you to watch them, and we also kindly request you to subscribe to our YouTube channel. The information provided here is for education and information purposes only and is not a medical advice. If you want me to make any presentations, please let me know. I'll be happy to do the research and prepare a video on that particular topic. If you would like to get a copy of my cardiology rotations manual to make your cardiology rotations experience enriching, please stay tuned till the end of this presentation. I will tell you how you can get a copy of this 175 pages of pertinent information for cardiology rounds. The feature presentation is ACLS EKG Interpretations. When we are looking at an electrocardiogram, there are a lot of things we need to focus upon. We need to have a systematic approach to diagnosing EKG strips. First thing, we need to look at the rate. We are looking at the ventricular rate. We are also looking at the atrial rate. Next, we look at the rhythm. Are the RR intervals regular or irregular? Are they regularly irregular or irregularly irregular? Then we look at the P waves. We look at the QRS complexes. We look at the STT segments. We look at the relationship between the P waves and the QRS complexes. We look at the T waves. Then look for any ectopic beats. Think of this P, QRS, and ST as a family. Here's a husband, then here's a wife, and here are a few kids. They're all tied together. When everything looks identical, it looks like a perfect family, like the pictures you see on the Facebook and social media. But not all families are perfect. We're going to see as we go along. There's going to be some trouble with the husband and wife, or with the kids, or with the entire family, like all in the family. And we're going to explore each one of those. Basically, you need to follow a systematic approach. First, the rate, the rhythm, the QRS complex, the P waves, relationship between P and QRS, ST segments, and the whole 9 yards. First, in order to determine the rate, we know that the EKG paper is run at a speed of 25 millimeters per second. From 0 to 1 second, we have 25 millimeters, which is divided into 25 smallest blocks. And each 5 block has a darker line, and that corresponds to 0.2 seconds. So if your first QRS complex is here, and the next one is coming at the darker line, which is 5 boxes, the rate is 300. If there are 10 boxes, the rate is 150. If there are 15 boxes, the rate is 100, then 75 and 60. So in this way, you can very quickly calculate the heart rate. On the other hand, if you are running a rhythm strip in an intensive care unit or on a telemetry, there are marks on the EKG paper which corresponds to 3 seconds. If you take a 6-second strip and measure the number of QRS complexes, that's your heart rate, and that is particularly useful in patients with rapid heartbeat or patients with irregular rhythms like atrial fibrillation, flutter, or multifocal atrial tachycardia. Here is a picture. What is your diagnosis? Please pause the video and go through this exercise. The main purpose of this video presentation is to teach you the steps necessary to diagnose an EKG strip. Not necessarily memorizing what these strips are, but learning how to approach each one of these strips so that you systematically find out what is wrong and how is it different, and then you use that principle to come up with a diagnosis. Here you got a family. They all look alike, look a perfect family. Yes, I think this should be on the Facebook. This is sinus rhythm. PR intervals are constant. The RR intervals are constant. The T waves are all symmetrical. Boy, what an ideal family I'm talking about. This is how you approach a strip. Here is a rhythm strip we got here. And this is lead 2, but we don't see any P waves. What happened? Ooh, we don't see any P waves. Here is one block and here's another block. So from here to here, like 150, but this is less than 10 blocks. So you're looking at like between less than 10, greater than 5. So this is 250 to 150, 300 to 150. So you're looking at like somewhere around 200, 220. So this is, we don't see the P waves. There may be a retrograde P wave here with a little notch. So maybe we are dealing with a junctional tachycardia. So that's how we come up with a diagnosis by exclusion criteria. Is this VTach? No, because the QRS complexes are narrow. And is it flutter? The rate is too fast for it to be flutter with 2-to-1 conduction. That is junctional tachycardia with a retrograde P wave. Here we have, as we can see, the rate here is, so this is around 220. This is similar to the tracing we had before. Again, this is most likely junctional tachycardia with some retrograde P waves, which are much more clear here, coming after the QRS complexes. The STT segments seems to be okay. So that is a junctional tachycardia with retrograde P waves. Uh-oh, we got a trouble in the paradise. We got regular RR intervals, sort of regular RR intervals. We got some narrow here, some of them are wider here. The most obvious thing is this sawtooth appearance. When you see a sawtooth appearance, then you think about atrial flutter. This is an atrial flutter. Is it atrial flutter with 1-to-1 conduction? No, because we got 1, 2, 3 spikes for each QRS complex. So this is atrial flutter with 3-to-1 conduction. The atrial rate is like 300 because this is one box. That's 300. So the ventricular rate is like 100. So this is atrial flutter with 3-to-1 conduction. Uh-oh, real trouble in the paradise. Here we have like a coarse ventricular fibrillation. It is not a regular VTach because we don't have a regular wide QRS complexes. This is not asystole. This is not atrial fibrillation. So this got to be coarse ventricular fibrillation. You had to run through your mind very quickly as what could it be. Don't jump into the diagnosis and say, okay, that's CT, that's it. No, that's not how it's going to work. So you had to go through this in a systematic fashion and say, oh, this looks abnormal. Is this VTach? No. Is this asystole? No. Is this atrial flutter? No, because this is not atrial flutter. We don't see big QRS complexes to complement this as atrial waves. The atrial waves too big to be atrial waves. This is not atrial fibrillation. So we are dealing with the coarse ventricular fibrillation. What do we got here? Okay, we got a regular tachycardia, which is almost like 300 here. All of a sudden, we have a CSP, that is carotid sinus pressure. When you have a real fast tachycardia with 1-to-1 conduction, like here, you don't know what the rhythm is, but we know it is supraventricular because the QRS complexes are narrow and symmetrical. The rate seems to be fairly regular. If you do a carotid pressure, it may block the QRS complexes and reveal the atrial flutter waves. So this is the atrial flutter with 1-to-1 conduction. Always remember, when you do the carotid pressure, first listen to the carotid for bruit. Don't press the carotids on both sides. You're pressing on one side and the medical student is pressing on the other side, and if you press both carotids, you know what's going to happen. Well, let's start off with the first family. The first family seems to be okay, P, Q, R, S, and T. And now we got another P here, something like P. So there are 2 P waves to each QRS complex. And the rate here is like from here to here is 150 to 100. So it is like 120 or something like that. So we have a R wave which is 120 and the P waves which are double that, which is 240. So we have something supraventricular with 2-to-1 conduction. What falls in a heart rate around 240 paroxysmal atrial tachycardia? So we have a paroxysmal atrial tachycardia with 2-to-1 block. Whenever you see paroxysmal atrial tachycardia with 2-to-1 block, always think about digitalis toxicity or digoxin toxicity. We don't see this very often in the current medical practice because we don't use digoxin so often, but nonetheless we should be thinking about that, especially if it's a renal patient and the patient is on digoxin. Again, I'm showing you a lot of different strips which you never see in your life, but how we are approaching is more important than what the actual diagnosis is. Here is a rhythm. The rate here is like, this is from here to here is 150, and this is like 160, 170, almost approaching 180. If this is less than 160, it could be sinus rhythm. Between 160 and 225, it is PAT or paroxysmal supraventricular tachycardia. So the rate is close to like 270, 280. I would say this is paroxysmal supraventricular tachycardia. One of the things that might help us to differentiate sinus tachycardia with paroxysmal atrial tachycardia may be the onset of a paroxysmal atrial tachycardia, which may be sort of spontaneous, a sinus rhythm, and bingo, you get a paroxysmal atrial tachycardia. I think we have an example I'm going to show you in a minute. Whereas with the sinus tachycardia, the rate may gradually go up and gradually come down. So that's an important point to keep in mind. Okay, what are we seeing here? Okay, we have a good looking family here, PRS, QRS, another family. Oh, we got this coming in early. Anything that is coming in early, you need to think about premature atrial beats, premature ventricular beats, or premature junctional beats. You can have a bundle of his beats too. But from practical purposes, whenever something comes before a regular cycle, think about premature beats. Is this ventricular premature beat? No, the QRS complex is narrow, so it looks very similar to the QRS complex before. Maybe increased voltage is premature atrial complexes. But if you look at 2 beats, extra beat, 2 beats, extra beat, 2 beats, extra beat. So this is like atrial trigeminy. Every third beat is an ectopic beat. Okay, here we got normal beat, premature beat, normal beat, premature beat, normal beat, premature beat. So this is atrial bigeminy. Why I say atrial bigeminy? Because I see a P wave here, sort of similar to the one we see here, and the QRS complex is very similar to the previous one. So it cannot be junctional bigeminy, it cannot be ventricular bigeminy, because the QRS complex looks very similar to the normal beat. What are we looking at here? Oh, the husband is missing here. The P waves are missing. It's QRS complexes. The rate is pretty slow. 1, 2, 3, 4, 5, 6. So this is like 50, approximately 50 beats per minute. We don't see P waves, and we see some Q waves in the ST elevation here. And if this is lead 3 or AVF, we are looking at an acute inferior myocardial infarction with junctional escape rhythm. So this is junctional rhythm, let's put it that way, because we don't see P waves. When we don't see P waves, then we have to think about junctional rhythm or ventricular rhythm. And depending upon the QRS complex and the rate, you decide whether it is junctional or is it ventricular. If we had a wide QRS complex and if the rate is between 40 and 60 or less, then you think about idioventricular rhythm. So this is not an idioventricular rhythm because you have a narrow QRS complex. So this is junctional. Now what do we got here? We got a regular beat, missing. The whole family is missing in action. And again, maybe regular beat. So here we got a sinus pause of almost more than 2 seconds. So this is sinus pause. The family is gone, out of town. We have no sign. There you go. That's how you sort of think of what is this. We see some regular QRS complexes. They look white. Then we see this sawtooth appearance. This is atrial flutter with slow ventricular response. If the QRS complex is wide, the first thing I would do is look at the electrocardiogram when the patient is in sinus rhythm or when the patient is not having any symptoms, and see if the patient has an underlying bundle branch block. So if you see an underlying bundle branch block, that's what it is. But the most obvious thing is the sawtooth appearing P waves, which is atrial flutter. So the diagnosis here is atrial flutter with slow ventricular response. What do we have here? Well, we got an intact family, intact family, intact family, intact family, but they're kind of going slow, aren't they? The family seems to be intact, but the rate is pretty slow. They are not making very... Is it junctional bradycardia? No, because these are sinus beats. I told you this is a whole family. Okay, what do we got here? Well, we got a straight family here. Whenever you see beats like this dropping, the first thing you need to make sure is, are we seeing a progressive increase in PR intervals? When you see a PR interval go from small, medium to large and then drop beat, what is that? Venky-Bach. But here we have a same PR interval, narrow QRS complex, looks okay, beat dropped, looks okay. This is not Venky-Bach because we are not seeing a progressive increase in PR interval, especially if you have 3 beats, it's much more easier, and I have an example of that. Dropping 2 beats, this is Mobitz type 2 AV block. Remember that. Mobitz type 2 AV block. What do we have here? Here we have a regular PQRS, wide QRS of course. It could be bundle branch block. We got a similar beat here. We got drop, similar, but it's very similar to the one we saw before, except that we have a wide QRS complex. I don't want you to mistake this to ventricular rhythm because this is still sinus rhythm with a bundle branch block, something like a left bundle branch block. And this is again Mobitz type 2 AV block. Here we have a regular rhythm, nice looking family. All of a sudden the family gets crazy here. Now from normal beat, extra beat, ding, they're running. The whole family is running. I don't know where they are running, but this is a paroxysmal supraventricular tachycardia with a sudden onset change from a sinus rhythm to a very rapid rate, which is approximately like 100 to 180 beats. When you see a strip like this, normal beats 3-4, and then all of a sudden it takes off, think about paroxysmal supraventricular tachycardia. Okay, what do we have here? Oh my gosh, getting a little more complex here, isn't it? We got a slow ventricular response, very slow ventricular response, because the QRS is wide, looks like a idioventricular rhythm here. But we do see P waves. Here's a P wave, here's a P wave, here's a P wave, here's a P wave, here's a P wave. But these P waves doesn't seem to be connecting. The husband and wife are not talking to each other. They are disconnected. So there is dissociation between the husband and wife. That means we are dealing with an independent atrial rhythm and an independent ventricular rhythm. This is complete heart block. See, when you correlate it to a family relationship, it makes it so easy to get through these strips. What are we seeing here? First of all, narrow QRS, supraventricular tachycardia, because there's too many QRS complexes. The RR intervals are varied. Whenever you see a varying RR intervals, that is irregularly irregular, there are 2 conditions that we need to keep in mind. One is atrial fibrillation, with or without WPW. The other one is multifocal atrial tachycardia. Is this atrial fibrillation? I don't think so. Say why? Because you see some P waves here. So when you see P wave with varying morphology, the P wave structures are different, then you have to think about multifocal atrial tachycardia, which is seen most commonly in patients with chronic COPD. So if they give any word like a patient with an oxygen level of 88%, or a patient with a chronic smoker, something related to COPD, then think about multifocal atrial tachycardia. Let's move along. Okay, finally we're getting what I was looking for. Okay, we have a good looking family here, the whole husband, wife and the kids. Same thing here, Same thing here, and it dropped. Wife and kids dropped away. Oh gosh. So let's see how the husband and wife are doing here. They're doing okay here. The husband is kind of lagging behind. He's lagging behind, and the family gone. So progressive increase in PR interval. So this is an example of Ventricular type 1 AV block. Ventricular, progressive PR interval increase. Progressive decrease in RR intervals. A dropped beat. The PR interval following the drop beat is the shortest one compared to the previous beats. Those are some of the features of Ventricular. There are a lot more features, but this should be enough for you to get your ACLS and get on with your work. What do we see here? Oh my gosh, no, I don't see any atrial activity. I see some wide QRS complexes, but it looks like they're going up here, they are going both ways, they're going downwards here. This is torsade point. This is going to be on the exam, so you might as well memorize this picture and make sure the QRS complexes are going in different directions, and you do see distinct QRS complexes, whereas with the coarse ventricular fibrillation, they may also be going in different directions, but you don't see a distinct QRS complexes in ventricular fibrillation. Okay, what's happening here? We got a slow heart rate, but the family seems to be intact. The QRS complex and the P waves and the T waves. So this is sinus bradycardia. What are we looking here? So if you look at the PR interval, this is 1, 2, 3, 4, 5, almost 6. The PR interval is 240 milliseconds. The normal PR interval is up to 210 milliseconds. Whenever you see a PR interval that is more than 5 blocks, which is 0.2 seconds or 200 milliseconds, you think about first degree AV block. First degree AV block. So they are going to give you one strip with prolonged PR interval. It may be like 240 milliseconds, which is much more obvious. But this is first degree AV block with the regular sinus rhythm. Okay, what are we seeing here? Well, let's look at the rate now. See, from here 1, 2, 3, that's 100. This is 150. So this is between 100 and 150. Let's close to 130. So this is, we don't see P waves before the QRS complexes. So if we don't see the P waves, we are already dealing with junctional tachycardia, or junctional rhythm, or ventricular rhythm. So this is narrow QRS complex. So I would say this is junctional rhythm with a retrograde P wave. This little notch here we are seeing. So this is junctional tachycardia. Junctional rhythm is between 40 and 60. The sinus is up to 60, and below that is escape junction rhythm. But junctional tachycardia is between 100 and 200. So this is junctional tachycardia. Sometimes they're going to trick you with a wide QRS strip. What is your diagnosis? What are your differential diagnoses here? The rhythm seems to be regular, but we got a wide QRS complex. Is this idioventricular rhythm? Is this ventricular bradycardia? We don't call it ventricular bradycardia, but we see a little spike here. Anytime you see a spike, ding, 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 think about pacemaker rhythm. So this is a ventricular pacemaker rhythm, which may mimic ventricular rhythm, and especially if the rate is very slow, it may look like idioventricular rhythm, because sometimes we may not be able to see the spike clearly in certain strips. Okay, what do we say here? Let's look at this family. This is fine, this is fine, this is fine, but look at the rate. Don't golly, it's very slow. Sinus bradycardia. This family is okay, this is okay, this is okay, this is okay, but there's an outsider here. Whenever you see something different, you think about an outsider. It doesn't belong to this family. So this is the outsiders could be from the atria or from the ventricle or from the bundle of hairs. This is a PVC. Why do I call it a PVC, not a PAC? We saw PAC before. We saw 2 strips with PACs. But look at the wide QRS complex, STT segments going in the opposite direction. So this is a PVC. Sometimes we may see PVCs frequently. They could be ventricular bigeminy or ventricular trigeminy. So always keep those things in mind. Oh, real trouble in the paradise. We got a regular family here, looks like, but we got trouble with STT segment. This is an acute myocardial infarction. STEMI. The next question is, where is the STEMI located? 2-3 AVF, inferior wall. 1 AVL, high anterior wall. V1 to V2, septal ME, STEMI. V1 to V4, anteroseptal ME. V1 to V6, anterolateral STEMI. You have to remember all these things. Inferior, high anterior, anteroseptal or anterolateral, V1 to V6. Oh, we got another one of these. Oh gosh. Where is the myocardial infarction? This is a STEMI EKG. Where is the myocardial infarction? V1, V2, V3. So this is anteroseptal myocardial infarction with reciprocal changes noted in the inferior leads. We are making progress. We can't even see the family here. All we see is wide QRS, regular wide QRS rhythm with a rate. This is like 180. So wide QRS rate of 180, which is regular ventricular tachycardia. We don't see any P waves. We don't even see STT segments. They are sort of buried in the QRS complex. But the key is wide QRS, regular rhythm, ventricular tachycardia. And here's a little bit slower rate, which is like from here to here is 150. This is 300. This is like 150, 165, 170. So 170 wide QRS. We don't see any P waves. Sometimes we can see some notches in the STT segment suggesting an occasional P wave trying to catch up. This is ventricular tachycardia. Here are short bursts of ventricular tachycardia, which you may see on a rhythm strip in the intensive care unit or on telemetry or on Holter monitors. Okay, what is this? This is not atrial flutter. We don't see any QRS complexes. So this is coarse. The rate is anywhere from 300 to 320 or something like that. So this is coarse ventricular fibrillation. Fine ventricular fibrillation is much faster than that, and the fluctuations are much smaller than. What are we seeing here? Look like some normal beats or maybe agonizing supraventricular beats. Then we get a short run of beat tag. This is serious rhythm problem. We got a torsade. What is your diagnosis? We don't see any activity at all. Just like a wavy baseline. No pulse, no respirations, CPR going on for 45 minutes. Given all the medications you can, done all the chest compressions, and this is what you're left with, asystole. So ladies and gentlemen, this is a 30-minute quick review of ACLS EKG interpretation. This presentation has been brought to you by Cardiology Seminars. This has been a presentation of Triple N Media. If you would like to get a copy of this Cardiology Rotations Manual, please send me an email to drniknikam@gmail.com. The email is in the description below, and I will be happy to send you a copy of this book. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel, and I will see you in the next video.